If a patient comes in with back or hip pain in the area, and we want to rule out the SI joint as the cause of the problem, one of the best ways to do that is by the Lateral testing. Lateral testing is a group of four tests to basically see if the SI is involved. We go in a systematic progression. We need two to be a positive test, and the first one we start is with the gapping. So with the gapping, what we do is we go to the patient's ASIS, we palpate it, then we use the heels of our hands to add some gapping. If this reproduces the pain in which the patient is here for, then it would be positive. This is also called the distraction test. Then after from here, if regardless if it's positive or negative, we would move to the thigh thrust test. So go on the patient's side that's more affected. We have them roll over to get our hand under the sacrum for a stable base, and then we apply a force through the hip, and we only do it if the person does not have a hip dysfunction. Then from there we move to the sacral thrust test, and we apply this force anteriorly for up to 6 reps. And this one does not have and we apply the force through the sacrum. This doesn't have as good as clinometrics, but it's good when used as all 4. For the final one, we move into the compression/approximation test. We lie on the patient's side and we apply a medial force to the bilateral innominate, and we would hold this for 30 seconds. I did not do that for the purpose of this video. Again, we're looking to reproduce that pain, and if the pain is brought up and the patient's complaints is brought up in 2 of the 4 tests, then it would at least be that there is SIJ involvement in the patient's problems. If a patient comes in and we're suspecting sacroiliac joint pain or causing the pain, then one great test we can do is the active supine straight leg raise test. So what I'm gonna ask my patient to do is if she could raise her left leg up, and then that would be difficult, so I'm gonna ask her to lower it down. Okay, so if that is painful and it's reproducing the pain that she specifically came in here for, then what I would do is I'll take my hands here and compress at her sacroiliac joint, and then I'd ask her to raise her leg again. If it feels better, then it would be a positive test. Passive instability. The last way we'll check for this instability is by using the active sling system, and we will do this by when my patient contracts her left, when she straight leg raises her left leg up, she'll bring her right shoulder towards that, activating her anterior sling system. If she feels better, then it would be from muscular instability at her SI joint. All right, another sacroiliac joint test that we can do is the prone straight leg raise test. So basically what I'm gonna have my patient do is she go lie prone on her stomach, and then I'm gonna ask her to lift her affected side up actively, and if that reproduces the exact pain that she came for, she can relax. Now I'm gonna add some compression to stabilize her and lift. If that feels better, then it could be positive for ligamentous instability. But if I'm suspecting that it could be muscular instability too, then I'll activate her posterior sling system. So I'm gonna ask my patient to put her arms down by her side, and then as she actively extends her leg back, she's gonna do her contralateral upper extremity, activating the lats with the opposite glute max and TFL. If it feels better, then it would be muscular instability. If If my patient comes in and I'm doing my exam and eval and it looks like there could be interarticular causes to her hip discomfort or pain into her hip, then the test I'd like to do is the scours test. So for the scours test, I'm gonna always start with the uninvolved side first to give a basic comparison, and then I'll go to the involved side. So when I do the scours test, I'll take the patient's leg. She's lying in supine. I'm gonna hold it up here, put my pressure on here, some external rotation, adduction, and then with my weight, I'm going to scour her hip through its socket. Just go back and forth, looking for her pain to be brought back on, and if so, then I'll ask where that discomfort is, because where that pain is could affect some of my interventions and some of the treatment diagnosis. All right, so this is the supine, the long sit. Basically, this is a great test to do if my patient comes in and she has sacroiliac pain, hip pain, knee pain, and we're just trying to see if there is a relative leg length discrepancy. Obviously, if we're trying to look for absolute leg length discrepancy, then the best way is to just measure it out. But for this purposes, this will get the job done. So basically what I'm gonna do is I got my patient lying in supine right here. I'm gonna ask her if she can bring her feet up towards her in a bridge position, and I'm gonna ask my patient to lift her bottom up from the plinth, and then I'm going to hold it, and then she's going to hold this, give or take a few seconds, say 5. All right, then we'll come back, and now after she comes down, I'm going to passively extend her ground to here. I'm gonna have my thumbs on her medial malleolus, looking for any leg length discrepancy. So my patient has a very slight increase in length on the right side, which could possibly mean that there could be a relative anterior rotation of the right innominate or a relative posterior rotation of the left innominate. So now to confirm that, I'm gonna ask my patient to sit up, and I'm looking to see if that discrepancy changes, and it does. So now the left one comes forward and the right one seemingly appears to go back. So then how I would treat this is I could do muscle energy techniques to try to get the muscles working, the antagonist muscles working to balance this out. If during my evaluation, I'm starting to think that there could be interarticular causes in the hip, which is making the pain or discomfort in my patient, the one test I'd like to do is the FABER. So basically what I'm going to do is there's going to be abduction and external rotation. So I'm always going to start with the non-affected side to give a basic comparison. So what I'll do is I'll passively take my patient up, the abduction, external rotation, and rest her foot here, stay nice and relaxed. Get out my tape measure from the femoral epicondyle down to the mat, making sure it's a nice straight line. Right. Then I'm gonna come put this back up. I'm gonna switch over and do this leg, and I'm looking to see if there's greater than 4 centimeters difference from an affected to affected side, then be a positive test. So if my patient comes in and it seems like there's intra-articular cause for her pain and discomfort in her hip, then I'll do the FADDIR test, which the ADDIR is adduction and internal rotation along with the F for flexion. So basically what I'm gonna do is I'm gonna passively take her into those 3 motions. So I'll take her leg, I'm going to flex it, adduct it, internal rotate it. Now, this is likely that it can cause signs and symptoms of pain, but when I ask her if it's painful, I'm going to make sure that it's the exact same pain that she came in the clinic for. So this test is positive if it reproduces the patient's pain that she came here for.
Across to the other hip.
If I'm working with a child or a young adult, then one of the tests for the hip that I'd probably do is the flexion adduction test. So basically what I'll do is I'll ask my patient to flex her, or I'll help her We'll put her foot right here, and then I'll tell her, with keeping her foot on the plinth, if she could have her knee go across her body. And basically what I'm looking for is to see if her knee can go to the other hip. All right, then I'd say put your leg back. And now we're gonna do the same thing with this leg. And so we'll bring the knee over, and then, all right, go back. So obviously with everything, we're comparing side to side, and then a positive test would be if the knee cannot make it to the other side, to the other hip. The clinometrics aren't as good with adults. So if my patient's complaining of signs and it's looking like it's intra-articular causes to her hip pain, then one test I'd like to throw in there is the labral test. So what I'm gonna do is I'm gonna grip above the knee and around the ankle area, and then I'm just gonna go back and forth, rolling it, trying to feel if there's a springy feel, making it come back or not. And I'm going to compare sides. I'm looking for asymmetry along with that springy feel. If my patient comes in and is seeming like there's a hip labral problem or tear, a great test that I can do is the anterior-posterior. We're gonna come here, I'm gonna passively take her up into flexion, adduction, external rotation, and I'm going to bring her into internal rotation, adduction, and come down here. So a faster version would be like this. And then for posterior, what we're gonna do is we're gonna come up in flexion, adduction, internal rotation, and we're gonna externally rotate and adduct like that. One more time, so it's gonna be like here. We're looking for signs and symptoms of pain and discomfort. What we're gonna do now is we're gonna do the Craig's test. We're checking to see if the patient has a normal femoral anteversion angle. So basically what we're gonna do is we're gonna have our patient lying in prone with a bent knee flexed at 90 degrees. And then we're gonna internally, externally rotate the femur until we find where the greater trochanter is most prominent, which will be an internal rotation. We got it right here. We're gonna measure it. So we got our stable arm in line with the floor, and then we're gonna measure down the line of the feet, tibia, and a normal reading would be between 8. Normal reading would be between 8 and 15 degrees. Hers was at 9, so she's normal. If I'm suspecting that there's a fracture in my patient's femur, then a great one that I can do is the Fulcrum test. So what I'll do is always compare side to side, start with the asymptomatic one first, then the symptomatic one. So for the purpose of this video, say I'm trying to test my patient's left femur. So what I'm gonna have her do is she'll be right here. I'll ask her to raise her knee up for me. So I put my arm under, then you can lower it back down. Then I'm gonna apply a downward force inferiorly above the kneecap. That way I'm not stressing the joint. I'll go like this. And then I'm basically trying to see if the pressure elicits a pain response in her. If it was painful and like excruciating, unbearable, yada, 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 then it would be a positive test for a fracture. And then if it was negative, then it would most likely indicate that there's no fracture in the femur. All right. So if we're suspecting that there's a fracture in the patient's femur, lower extremity area, then what we can do is the Patellar pubic percussion test. So basically what I'm gonna do is I'm gonna ask my patient, I'm gonna explain to them that that bone under their belly button, they can put the stethoscope on there, preferably under their pants, so that way it's only over one layer of clothes. So patient, can you put this on your pubic bone for me, please? That bone, there you go, under your belly button, that last bony part left. All right, thank you very much. Then what I'm gonna do is, I'm gonna compare side to side. I'm looking for a nice, crisp wooden door knock-knock sound. If it sounds muted, then it's very likely that there is a fracture and we would send them out. So I'm gonna have my hands on either side of the patella, secure it, and just go knock, knock, knock. And then after I do that, I'll also compare side to side and look for differences. very much, patient. Since there was both good knock-knock, crisp wooden sounds on both sides, it'd be a negative test on either leg. All right, so now what I'm finna do is I'm gonna test the muscle length of my patient's quads. So I got, we're gonna do the Eli's test. I got my patient lying in prone right here. So again, we're always gonna compare side to side. We're gonna start with the side that's not symptomatic and then compare that to the symptomatic side. For the purpose of this video, we're just gonna do one. So basically what I'm gonna do here is I have my hand on her.
Can you still see that, or should you go to the other side?
Oh. I'm gonna go over here so you can see me. And then I'm gonna put my hand up here, so if I can feel at her hip, if there's any hiking as we're flexing the quadricep, we're just gonna bring it up here. So as she flexes her knees and we see that the hip begins to tilt up, and then there's also a space in between where the femur is no longer on the plinth, it would show that there is a tight rectus femoris, because that is limiting its being able to flex without compensation at the hip, and the rectus femoris crosses the knee and the hip. All right. If a patient is coming in with sciatic-like pain, and one way I can test it is with the Piriformis test. So we'll always start with the non-affected side first, compare it to the affected side to give it a base of reference. So basically what I'll have my patient do is I'll have him lying in side lying right here, and then the side that we're testing is gonna be up. I'm gonna 60 degrees like up here, and I'm gonna secure here and here, and I'm gonna overpressure with the Piriformis side stretch. And basically if this reproduces the pain that he came here for, then it would be a positive test. Pain from the Piriformis could be from a glute max, which is not working well for reasons of weakness, or from lumbar back pain, which is enabling it, causing the Piriformis to pick up the slack as a hip extensor, which would then cause it to be overworked and become problematic and symptomatic. Seems as if he has gluteal weakness. One test that I can do is the Trendelenburg test. So basically what I'm going to do is have my patient stand on one leg. I have a table next to him to do support, just in case if he needs it. We're not going to press on it, just have his hand right there so we don't get a foosh. All right, man. So what we're going to do is we're going to stand up on your right leg with the left leg up. I'm just going to hold that for 30 seconds. For Dr. Hess's sake, we are not going to make this video 30 seconds long. If we see the drop, then it would be positive, and then we would always compare it side to side. So fast forward 30 seconds, and then we switch legs. Again, on top of looking for the drop, we can also compare side to side. If both drop but one lasts longer, that would also be something to note and account for in our treatment. Resisted external derotation test. So what I'm going to do is I'm going to take my patient up to the 90-90. I'm going to bring her here. I'm going to apply pressure here and here, and she's going to internally rotate and fight against me, and that would be positive. I'm just making sure that she's not extending her knee or doing any weird compensations in doing so. That would give a false negative. Truly rule out gluteal tendinopathy, then we would perform this test in prone here.
Next one on the
Bring her into resisted external rotation. I'll tell her to bring her foot towards me. All right. And if that was positive, then it would be positive for a possible glute med tendinopathy, but since it's not, it'd be negative. That's reproduction and pain. All right, yo. So I'm finna do a hip distraction on my patient's left lower extremity. Got my distraction belt on, cross over my forearms for support, and then I got my buckle on the side so it's not gonna be in the way. Got my patient lying in supine. So what I'm gonna do is I'm gonna grab above my patient's ankle, and then I'm gonna get in a lunge so I don't do a jet skier. And then I'm just gonna pull back and release. This is a sustained hold, and blah blah blah, da 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 da. So I'm gonna do a lateral hip distraction. Basically, I have my distraction belt. It's around my gluteal area, and then I have the rag on my patient's inner thigh. I'm supporting laterally on his knee, and I'm holding his distal around his tibia up above his ankle, so I'm not on that joint. Then I'm just going to tilt my butt back, and then that will cause the lateral distraction. Yeah. All right, so now what I'm gonna do is a posterior-anterior glide of my patient's right femur. So basically, I got my patient lying in prone. Whatever side that I'm going to mobilize, I have glide is closer to me. I have my gait belt above his knee, so that way I'm not like torquing on his joint. I palpated for the greater trochanter, then I came anterior. Now I'm gonna give my force. And then my left hand is more just balance. I'm not really pushing over here, putting my weight through here. If my patient's in pain and discomfort, I would do a grade 1 or 2. And if I'm trying to increase mobility, it would be grades 3 or 4. Okay. So right now I'm going to do an anterior-posterior glide of my patient's femur. So basically what I got him lying down in supine. I have my distraction belt right here. So I have it over my left shoulder. And then what I did is I got him up into some degrees of flexion. I palpated for his greater trochanter to know where the head of his femur is, and I'm coming more anterior over here. My left hand is just more for like balance and support. I'm not just yanking on him. I just have it like right here to be comfortable. Then I'm just going to give some light mobilizations, pushing from anterior to posterior. Grades 1 and 2 for comfort, grades 3 and 4 to increase mobility.